Hi, it's Dr. Centeno, and thanks for joining us today. We're going to talk about using translational BAI to diagnose craniocervical instability, or CCI. Now, translational BAI is a very common metric that's used on flexion-extension radiography, really flexion-extension upright MRI, to diagnose craniocervical instability. As you may know, I'm out for 6 weeks, but I've prepared 5 lectures on CCI topics that will be on YouTube and Facebook Live on Fridays at 1 p.m. MST and 3 p.m. EST. So why is it critical that we have good measurements that help us diagnose CCI accurately? Well, if our measurements are also found in normal people walking around in the street, that we think are related to CCI, then we're likely to make an inaccurate diagnosis of CCI. And CCI symptoms have so many overlaps with so many different other diseases that if we make an inaccurate diagnosis of CCI, it's unlikely to work in someone who doesn't have CCI. And then obviously exposing someone to a surgical risk who doesn't have CCI is problematic at lots of different levels. And for every measurement made in an imaging study that leads to a diagnosis of CCI, we need the following. We need a study where the measurement is made on normal controls, showing that measurement is rarely or never found in patients without CCI, and a study of measurements in patients with CCI that shows the measurement is very different than those types of measurements found in normal controls. Regrettably, a lot of neurosurgical values that lead to surgery don't have both of these pieces of evidence. And that's very concerning, right? Because many of these surgeries are quite big and have big potential complication rates. So we got to get this right. So what is BAI? It's the distance between the basion and a line drawn at the back of the dens. So it's basically measuring the degree to which the skull may have slid forward on the neck. Now, translational BAI is just measuring BAI and flexion and extension and then comparing those two. Now, translational BAI under 1 is considered stone cold, normal. Bottom line, for surgery, the thought has been you needed to have more than 4 millimeters of translational BAI. And that's really based on a paper by Henderson et al. So we're going to look at that today. Does that still make sense with more recent data that's been collected on upright MRI? So where does that 4 millimeter number come from? Well, the reference given is this paper by Henderson, where he talks about very reasonably that the normal BAI measurement says no more than 1 millimeter between flexion and extension. We added 3 to that for error. Seems pretty reasonable. So we use a BAI or translational BAI measurement of 4 millimeters. So it all seems pretty reasonable. But is this accurate? Let's test that, because we want to test all of these measurements, because obviously, again, if we identify falsely someone with one of these measurements as having CCI who doesn't really have CCI, then we've got a problem on our hands. So this is the new study that was just published last year in upright MRI. Good news and bad news. The good news is it did look at normal controls. The bad news is it didn't really have a symptomatic CCI group, but it does at least allow us to say, what should this normal number be? So this is my graphing of their data. And you can see there for extension, neutral, and flexion, I've graphed their numbers. These are normal controls. So extension, the range was 2.7 to 3.7, and flexion on the bottom, the range was 4.8 to 6.2. Now, if we look at the normal maximum motion between the 2.7 in extension and the 6.2 in flexion, that's going to come out to about 3.5 millimeters. So that should be our normal max, meaning these are normal patients. They have 3.5 millimeters. So we certainly can't say that someone who has 2 or 3 millimeters of translational BAI has an abnormal measurement, because there's people walking around out there with that measurement. Hence, 3.5 or 4 millimeters are pretty good metrics to use to determine an abnormal BAI. So in summary, the 2019 quoted Henderson criteria of 4 millimeters or greater looks pretty solid. It actually agrees with the study on normal controls done by Nicholson. So we now have normal controls on upright MRI to compare to. Hence, using a 4 millimeter cutoff is a pretty good idea. I'm very comfortable with that. And that's what we use. So again, this is just another deep dive into a measurement that's used to diagnose CCI. And very important that we do this periodically to make sure the numbers we're using to diagnose CCI are accurate. So everyone have a great weekend, and I'll be back doing actual live Facebook Lives here before you know it. Thank you.